Upfront and Outspoken with Bob Williams. If you love the Constitution,
man is not free unless government is limited.
If you love freedom,
as government expands, liberty contracts.
If you believe in personal responsibility, if you believe America is still the greatest nation on earth, then get ready for an experience you'll never forget. This is Upfront and Outspoken. Here's your host, Bob Williams.
Some folks are born made to wave the flag. Ooh, they're red, white, and blue.
And this is Bob Williams. Welcome back to Upfront Outspoken. Wow, what can I tell you? I have a great guest on the phone. We've had her on before, and she talked about, the last time we talked about the EBD 68 enterovirus, and it's always a great pleasure having her on. And this time around, we're going to be talking about something very, very serious that's on everybody's mind. On the phone with me, of course, is Dr. Kristy Bradley with the Oklahoma State Department of Health. Welcome back to the show, Dr. Bradley.
Well, thank you, Bob. I'm happy to be here.
You know, it's on everybody's tongue. You know, I mean, no matter where you're going these days, everyone is concerned about this Ebola. You know, when there's now 2 confirmed cases in Texas. In fact, the last confirmed case we heard on the news traveled from Dallas to Cleveland, back to Dallas, and she was showing some very, very early signs of the Ebola virus. And our concern is, what is the Oklahoma Department of Health going to do in the event something like this might come here?
Well, we have some time. A lot of people think that you have to start from scratch and build up a specific Ebola response plan. But our approach has always been, since 9/11, that we have to prepare using what we call an all-hazards emergency preparedness plan. And the elements of that: communication, coordination, explicit ways that we would respond to certain infectious diseases, such as the use of quarantine or isolation orders. Those are all contained in what we call an all-hazards emergency response plan. So we just annually review that and update it and see if there's any gaps that need to be supplemented to be sure that we can respond. We started to inform our healthcare clinics as early as July 29th of this year, the serious outbreak of Ebola occurring in West Africa, and urged them to start reviewing their protocols and procedures for screening patients that might come into their facility with a travel history to those affected countries in West Africa, and fever and other symptoms that may be consistent with Ebola.
You know, so exactly what are the procedures a hospital is supposed to take when there's even the suspect of this particular virus?
Well, all of the hospitals are supposed to be implementing a triage process where they will ask a patient who comes in complaining of a fever and other symptoms like headache, body aches, abdominal pain, vomiting, diarrhea, unexplained bruising or bleeding, to immediately ask them if they have been to an Ebola-affected country within the previous 21 days or had very close contact with someone who was sick from those countries, and then place them into isolation and then basically go into their protocol of safely handling that patient for further evaluation and interview to determine if they might be a suspected case. At that point, they also should be contacting the Oklahoma State Department of Health epidemiologist home, and we will help facilitate that consultation and questioning. And then if we jointly decide that, oh my goodness, it looks like they are a possible case of Ebola virus, then we will go into the next step, which is collecting a blood specimen to send to the CDC for testing.
Okay, the question that I have, you had mentioned the fact of this questionnaire. What are some of the questions that are asked? We know the basic one would be, have you been to any of these countries that are affected by this, or have you been in contact with someone who has? What are some of the other questions that are on this thing?
The other questions have to do with, have you been a healthcare worker in one of those affected countries, and if so, did you have any unprotected exposure to a patient who was known or suspected to have Ebola? Did you participate in any funeral rites involving a person who may have died of Ebola? Were you in contact with anyone who may have had Ebola in that country? And that places them in various risks. The other very important feature is into clinical testing. A lot of persons that travel to West Africa contract malaria or possibly dengue fever, typhoid fever. So the physician will also order tests to rule out other more likely causes of their illness.
Okay,
If the tests are negative, then that makes Ebola a little more likely.
The question, it was brought up to me, a couple days ago, that on this questionnaire, somebody could lie. I mean, is there any stopgap measures against a person lying on this thing?
Yeah, well, you're probably referencing the questionnaire that is more for screening before the persons leave the country and board a commercial airplane. And that's where there's been more concern about persons not being completely factual in their responses. I think that's less likely to occur when a person is sick and actually in a hospital. They're more compelled to be honest with the physician because they know it's in their best interest to get the appropriate treatment that they need.
Yeah, but the thing is, I'm concerned is, let's say, this is an extreme hypothetical. All right, let's say we have an individual who may on a plane, is not symptomatic, who comes into this country, who may have lied on their application, wherever they were from for whatever reason. Are they not then almost a potential time bomb set to go off here in the U.S.? Almost like a viral terrorist. What assurances does the American public have that this isn't going to happen?
Well, the situation you're describing, Bob, is quite similar to what occurred with our first travel-associated case in the U.S. that happened in Dallas, where he arrived in the U.S. And was asymptomatic for 4 days, was incubating the disease, and then became ill with Ebola. And subsequently, we're seeing now a number of people that are being monitored as a result of that as possible exposure to Ebola. There's, of course, not 100% way of knowing that every person has been honest in their screening that occurs at the airports. Just this week, an extra layer of screening was implemented at the 5 key airports.
Okay, this extra layer, what are you referring to?
Pardon me?
The extra layer of precautions that are being implemented. Do you know what that extra layer is?
The extra layer of screening that I was referring to was now when persons arrive from those countries in West Africa at 5 airports in the U.S., where over 90% of the people coming in from Guinea, Sierra Leone, and Liberia either come through Chicago, New York City, Washington, D.C., Newark, or Atlanta. There are teams of federal government employees there that are conducting additional temperature taking and screening. And then if they have a fever or if they then report that they may have had some exposures, they're placed into detention and not allowed to get back on another commercial jet to go to their ultimate destination. So
hopefully that will curtail people from bringing it in, and it looks like when we first heard about this, when we first very first time we heard about Mr. Duncan, and this has escalated to a very serious point in that initially it was just Mr. Duncan. Then it became, his immediate family. Then it became 18 potential other people. Then it became 48. Now it's up to 124. Now we're learning that the second patient traveled all the way to Cleveland and back. Therefore, and she was very low. She had a very low fever. 132 people aboard that aircraft. I mean, this thing. We're being told we have this under control, but by looking at it, do we really have this thing under control?
I think that we do. I, though, understand, and we ourselves in the public health community were not expecting to hear of another healthcare worker case. So, understandably, that's caused a little ripple of doubt among most people. But we have always known that healthcare workers who are caring for a patient are really the most in that hot zone, if you will.
Right.
Because they're the ones that are having routine, very close contact with the most contagious bodily fluids that a patient has at that time and are at much greater risk. Also, keep in mind that Mr. Duncan was quite ill and was on a ventilator and was on dialysis, and those specific medical processes could have exposed these healthcare workers to more blood and bodily fluids than what normally would be encountered by others. I mean, those are the type of things that are being evaluated very closely right now, and leading to some refined processes and procedure for healthcare workers caring for Ebola patients.
Now, the question that even the head of the CDC said is that this is a contact virus. Okay, and the only way that you can get it is if a patient or a individual becomes symptomatic of it, which, to me, that would mean, okay, I see a guy sweating, he's going to have sweat in his hands, he touches something, he's going to leave a germ there. We know that the second victim left Dallas with a temperature of 99.5 degrees. So she had to be showing some early signs, which is, to me, probably the sweaty. How could we not have seen this coming?
Well, I don't know the exact details. I've heard conflicting reports of whether she was told she shouldn't be flying on a commercial airplane versus others that said she was cleared to. So that, I think, is still being sorted out. But she was screened and classified as a lower risk exposure because of the personal protection equipment she was using in her job and caring for Mr. Duncan. So without actually being involved in her contact tracing, I don't know what the communication was to her in terms of recommendations for her restriction of movement. I think, though, what's very important and is reassuring is the number of close household contacts and other people that had contact with Mr. Duncan while he was sick, and none of those persons have developed Ebola. And they're almost at the end of their full 21-day monitoring period, so that's very reassuring. But again, that healthcare setting is where there's the most risk because you have the most possible contact with a large amount of blood and other body fluids.
Now, the one final question I want to ask you is the protective clothing that a person, if they're going to be coming, if a nurse or a healthcare worker would come in contact with these type of patients, or basically anybody that has a virus that could do this, what's the standard in a hospital? Let's say if I go to the emergency room, say here in Sallisaw, or I go to the emergency room here in Podal, what's the standard garments that they would wear if in fact I'm sweating profusely, or that. What's the standard garb that they wear?
And standard is the right word because we have a terminology of standard precautions. And if the person is coughing or showing respiratory symptoms too, along with the fever, they would go into what we call standard contact and droplet precautions. And so the protective equipment is a regular face mask, like a surgical mask, a gown that is fluid resistant, and gloves. And then as an added precaution, those persons, if a negative pressure airborne isolation room is available, that the patient be escorted as soon as possible into an isolation room and then only be evaluated and cared for by persons wearing the gown, the mask, and the gloves.
Now, how many hospitals here in Oklahoma are set up with the ability to actually deal with a Ebola case, or do we have to send them to Nebraska or Atlanta?
Well, in the initial evaluation stages, obviously someone who might be just becoming ill with Ebola could potentially walk into any hospital in Oklahoma. And so this is why we've recommended and advised that all hospitals be on alert for that potential and put processes into place to do that initial screening and evaluation and this initial days of care. And all of our acute care hospitals should have that capability of having an isolation room, having trained personnel, and having the appropriate personal protection equipment on hand.
But my question was, how many are actually equipped to handle a patient like Mr. Duncan? Do we have any here in Oklahoma?
Yes, we do have hospitals in Oklahoma that have the ability to care for an Ebola patient. That is something that really would need to be determined on a case-by-case basis, depending on the type of symptoms.
Well, let's say the worst scenario.
Disease. The worst scenario, like Mr. Duncan, where they were going into multi-organ failure and having a lot of bleeding and kidney failure, that would require treatment probably at a more advanced facility because you have to have the ability to handle very critically ill patients. And so we do see transfer patterns within the state, of like serious injuries like car accidents or serious kidney failure cases and things like that are usually have a transfer pattern to a more a hospital with more intensive care facilities. So but I think it's important to remind everyone that every hospital should have the ability to do the initial evaluation, assessment, and begin the initial care. And then if we should have an Ebola patient in a smaller or medium-sized hospital, that would be evaluated in terms of the need to transfer that patient on staffing levels at that facility and the degree of seriousness of the patient. So find the best facility for their care as well as the protection of the workers.
Well, our time is almost up, Dr. Bradley, and I want to once again thank you for coming on so early in the morning and answering the tough questions that, it seems that few other reporters are asking. I want to thank you again for coming on and answering the tough question.
Well, you're very welcome. I mean, the most important thing we can do during stressful times like this is to have these open dialogues and share information, understanding that this is a very evolving situation. We've never had a case of Ebola in the United States prior to late September, and so we are going to be learning as we go and modifying our processes and procedures as we go and learn from what's happened in Dallas.
Well, once again, Dr. Bradley, thank you again for coming on.
Oh, you're very welcome.
And I look forward to talking to you again soon.
Okay, thanks, Bob.
All right, bye-bye.
Bye-bye.
That's Dr. Kristy Bradley with the Oklahoma State Health Department. And like I said, these are questions that everybody's been asking. It's on everybody's mind, and I thank Dr. Bradley. I really do. I thank her very much for coming on. I was afraid she was going to hang up on me when I started answering the tough questions. But these are questions you need to know. You need to have answers, too. You need to know what is going on here. So once again, thank you, Dr. Bradley, for making an early morning come around on my show this morning. And with that, it is time for me to get on out of here. I want you to stay tuned, because coming up here at the bottom of the hour, the one, the only, Ed Till will be with you all the way up until 4 o'clock this afternoon. So until tomorrow morning, this is Bob Williams. Take care of yourselves.